Joining us now, Miss Getty Israel, founder and CEO of Sisters in Birth. She's also a population health expert, author, and mother. Welcome, Miss Israel. Good to see you again.
I'm glad you remembered.
Yeah,
Thank you.
I do. Yeah, you were in here. It's been a few months, but you and I think
Dr. McMillan.
That's right. Mm-hmm. That's right. What accompanied you? So we had a good discussion. Move up a little bit closer to the mic there. Yeah. Okay. All right. So tell us what your organization does, the Sisters in Birth. Tell us about that.
Well, it does two significant things: providing clinical care, namely midwifery care, to pregnant women, particularly Medicaid pregnant women. Mm-hmm. And we also provide evidence-based community health services through our community health workers that focus on health education, weight management, like obesity counseling and nutritional counseling, addressing a population that has a high rate of obesity that leads to maternal diseases and poor health outcomes. So we've integrated those two services under one roof, where patients get the clinical care as well as the non-clinical care. But it's all about preventing diseases.
Okay, so is it mostly focused on preventing diseases postpartum?
No.
Okay.
The thing about postpartum diseases, those diseases, the risk factors for those diseases usually occur before postpartum.
Yep. Okay.
So it's all about addressing those diseases those risk factors as soon as a person comes through the door. The typical pregnant woman who comes through anyone's door in Mississippi is going to be overweight or obese. On average, BMI of 30. That's obesity. And so our goal is to help that patient to achieve a healthy, evidence-based recommended weight gain. How much weight should she gain during the course of the pregnancy? Many OB providers don't engage women about their weight. They don't talk to them about nutrition. They don't encourage them to exercise, like walking 30 minutes a day. Very simple, modest steps that women need to take, even before they become pregnant. If they're in the reproductive age group, they can become pregnant. Most women in Mississippi in the reproductive age group are overweight or obese. We have the highest rate of pre-pregnancy obesity and prenatal obesity. So these two risk factors lead to bad postpartum outcomes. They lead to bad birth outcomes. They lead to maternal diseases like hypertensive disorders, preeclampsia, heart disease, diabetes during the pregnancy, and can kill that person during the pregnancy or afterwards. And it usually happens. There were like 51 deaths, pregnancy-related deaths, that occurred between 2013 and 2016, according to the Mississippi Department of Health.
In Mississippi, we're talking about?
According to Mississippi Department of Health data.
Okay.
49% of those deaths occurred during the 6-week postpartum. 14% occurred during pregnancy. The other 37% occurred after the 6-week mark. So these disorders don't wait until a woman has a baby to surface. The problems are already there. The risk factors are already there. Problem is we're not addressing those risk factors. So I know there's a big argument and a big push and a controversial push to extend postpartum Medicaid. My argument is it would be pointless to extend postpartum Medicaid if we're not going to address these underlying issues the moment she comes through our doors. And doctors are not suited, they're not educated, they're not trained or skilled, neither is their staff, to do this. So what we're advocating for...
To do what exactly?
To provide an intervention, a structured, face-to-face intervention that takes a woman through the steps of changing diet, changing behavior, taking responsibility for your health. A big part of healthcare and health outcomes is taking responsibility for your health. Over 85% of chronic disease medication is for diseases that can be prevented if we simply lose weight, if we stop smoking, if we stop drinking too much. That's public health. Public health is on the outside of healthcare. Doctors don't understand public health. So I'm advocating for public health. I'm saying if we're going to extend Medicaid, you should at least require and make available to this population a structured evidence-based intervention like the CDC's Diabetes Prevention Program, which is nothing but a weight loss program, which I've put in place in 4 different settings: in a community college, for pregnant women in rural Mississippi and urban Mississippi, and I've done it for the general adult population. So if those people can change diet, and exercise, do simple things like that to lose weight, you will see diabetes being prevented. You'll see it being reversed, heart disease being prevented and reversed. The problem is there are no structured programs in place in our communities, community-based programs, not led by nurses, not led by doctors, but led by lifestyle coaches who are trained and skilled in this area. That's what we should be doing, and we don't want to wait until the postpartum period to do it. We want to do that as soon as possible. That should be going on through primary care. Most women who become Medicaid eligible haven't had a primary care visit in 1, 2, 3, 4 years. I asked this question. So what are they doing during the interim before they become pregnant? I'll tell you what they're doing. They're eating fast food every day. They're drinking soda. They're drinking sweet tea. They're developing abdominal obesity. They're developing hypertension or pre-hypertensive disorders. They're becoming pre-diabetic. So what happens when they become pregnant? The problems magnify. Obesity needs to be treated as a disorder. It is the elephant in the room that neither the Republicans nor Democrats want to address. Doctors don't address it. Hospitals don't address it. No one addresses it. It's a public health issue, and it needs to be treated as one. And simply giving women more access to doctors who are going to medicate them or maybe perform some invasive therapy will not change the underlying problem. Let me ask a question. What happens after that 1 year is up? Let's say we extend it for 1 year. What happens when the 1 year is up? If that person hasn't changed her behavior, if she's still obese or very much overweight, she's still at risk of experiencing the same disorders and the same deaths.
Well, yeah, so what I'm hearing from your discussion there, Ms. Israel, is that the doctors, the providers appear to be more focused on just treating the disease with whatever tools are available to them medically, and not really talking to individuals about prevention through changing their lifestyle. I'm a little astonished to hear that, in all honesty, that you're saying that I think I heard you say that the providers, the nurses, et cetera, medical staff, professionals, don't even know how to do that.
They're not trained. Medical students are required to get, I think, only 1 3-credit-hour course in nutrition. Where does that training come from? If a doctor or a medical student doesn't go beyond and get continuing education in something like public health or nutrition or physical activity, they won't learn it in medical school. They're not required. They are trained to treat diseases with medications.
Right. I've actually had doctors say this to me, and you won't find this as a shock, but some of our audience might, where they have counseled patients to change lifestyle, just as you were talking about, diet, smoking, lack of exercise, other bad habits that contribute to obesity, diabetes, prediabetes, hypertension, et cetera. And when they have counseled them about changing lifestyle, the patients have actually said, yeah, Doc, but you're still going to take care of me, right? And the government's paying for that care. Well, yeah, I'm going to take care of you. I'm bound to do so. But I'm telling you to improve the quality of your life,
right,
and protect against perhaps serious disease and even premature death, you need to change your lifestyle. I mean, there's a limit to what can happen and what we can do here with medicine. So it seems like we don't really have a willing population. And then maybe this is just an anecdotal, isolated case. But what I'm sort of hearing from your discussion is that this is happening a lot.
It does happen a lot. We're the fattest state in the country. And you're right. There's not a willingness among the population, among most of it, but doctors they don't have the time, they don't have the qualifications. It takes a structured program. Let me just explain what the Diabetes Prevention Program does.
Sure.
It's an evidence-based program. I think it was first published in 2004. That program uses not doctors, not clinicians, but individuals who are trained and certified as lifestyle coaches. That lifestyle coach will use a curriculum. That curriculum addresses nutrition. It will meet once a week with a group of people who are overweight. Those people will go through a curriculum learning about nutrition, how to change behavior. They'll be coached through the process. And in addition to that, what we did was we actually exercised or led structured exercise sessions, at least 30 minutes, with our participants. Those participants were then required to walk at least 30 minutes to an hour a day. Those participants then started their own walking groups. And from that point on, it began to grow. Every week we checked their blood pressure, we checked their body measurements to see if they were losing or gaining. There were over 1,200 pounds lost among two groups right there in Natchez, Mississippi. Now, most of the people who joined did drop out because they did not want to make the changes. But here's the thing.
Hold that thought. We'll continue the discussion on the other side of the break.
Okay.
Thank you. We've got Getty Israel, founder and CEO of Sisters in Birth, in the Element Wealth Studios. Stay with Element Wealth Studios, SuperTalk, Mississippi. We've got Getty Israel, founder and CEO of Sisters in Birth, also a population health expert, author, and mother as well. So the thing that always strikes me about this issue is it's got so many aspects to it.
So many layers.
Right. So you've got the financial aspect. You cannot ignore that. Healthcare costs money. And honestly, when folks so disease is such that it's not selective. You know, it doesn't say, well, I'm going after this segment of the population. Some of it is just inexplicable. You just contract diseases, and we're still trying to understand that.
Regardless of what you do.
Right. And then a lot of it is, well, you led a lifestyle that contributed to it.
Significantly.
Right. And promoted it.
Significantly.
And you ended up sick, essentially. And then the other aspect of it is there's a moral and an ethical piece to this. We're, thank God, in this country, despite what a lot of people say, we take care of everybody. We don't deny, for the most part, we don't really deny care. There are some nuances to that, but in general, all you have to do is go to any hospital in your area and see what flows into the emergency room.
If there is one in your area.
If there is one, right. But most of those, honestly, it's a losing proposition from a financial perspective. But it's a complicated moral and ethical issue. And I think the point I'm trying to make there, and then I'll be quiet and let you talk, is that you were discussing quite eloquently mothers in particular that are before they get pregnant, they're leading poor lifestyles. That causes problems while they're pregnant. Then they continue those poor lifestyles while they're pregnant, and then often don't discontinue them postpartum. And many times they're left with permanent disease as a result of that. But from an ethical and moral perspective, we're still going to do everything in our power as a society to take care of them. But some things we honestly can't cure. And then on the other hand, so much of that was preventable. But it requires
personal responsibility.
That's right. And that's an issue that is, I think, front and center in our society and our country in general across a variety of areas. But they've got to be willing to adjust and be willing to adopt these lifestyles. You made a point about their diet. And so many folks in the rural parts of our state, they're in food deserts. They lack access to anything they could afford besides the bad food, honestly, the junk food and the fast food. All you got to do is go through some of the rural areas of Mississippi, especially in the Delta. That's pretty much what you see from a restaurant perspective, and that's the diet. And in many cases, all those folks can afford. So your work here, you're trying to change that. You're trying to impress upon people, and I'm not trying to put words in your mouth here, that, yeah, you really should change your lifestyle. It's in your best interest. It's in your baby's best interest, pre, during, and after birth. And you're working and trying to educate. I get that. I read your article. It was excellent, published in the Tennessean, and you make the point that, you just as you said, you make this point in your article, we're the most obese state in the country, and I think some of the other health measurements as well, we're at the top of the list of hypertension and heart disease and diabetes, et cetera, and all of these long-term bad health outcome consequences. What do you need from a public policy perspective, if anything?
I think Medicaid is in a position to require some personal responsibility.
Okay.
I think look, we're covering 65% of pregnancies. I come across people.
Medicaid we're talking about.
Medicaid
Yeah.
is. I
That's
come
right.
across people who have private insurance and who will drop it and apply for Medicaid. And everybody who's on Medicaid is not really eligible for Medicaid. But let's
Right.
just say let's say most of them are. Well, if we're going to give you free insurance, we should ask for something in return so we can do what? Improve quality of life of all our citizens and reduce medical costs that taxpayers are paying for. What does that look like? Well, I shouldn't have to fight with a patient, beg a patient, plead with a patient to come to a health education class that will teach her how to eat healthy and that will engage her structurally in exercise.
Yep.
Right? Medicaid can say, if you want Medicaid throughout your pregnancy, you got to go to that class. Why is that so difficult? Why can't Medicaid require Medicaid patients through health plans or traditional plans, pregnant or general population, to participate in health education programs that the health plans should be providing? The health plans are not providing structured, intensive, evidence-based interventions to address obesity. I've talked to them. What they offer is someone who may call you on the phone once a month if you're considered high risk. That doesn't get it done. What gets it done is a structured program like the diabetes prevention program that we should have in every county or every community in Mississippi. And once it's there, health plans develop it, hire lifestyle coaches to facilitate those classes once a week, include coaching and education and exercise. It's really simple. Prevention is really simple. It's always been really simple. You are required to go. We're taking roll. You don't show up for your classes. You don't adhere to the class criteria. We drop you from Medicaid. Responsibility. Medicaid patients don't have to pay for anything. And there's a sense of entitlement among many of them. They want everything to be free. Well, if it's going to be free, we should ask for something or demand something in return. And the best thing we can demand in return is that we put these programs in place across the country, across the state, and require them to be engaged to go and participate. We also need to treat obesity as a disorder. It is the elephant in the room that everybody ignores, even though it is strongly associated with almost every chronic disease known to mankind. Why can't I bill for obesity? I can't bill for obesity counseling.
Okay.
Not through the health plans, not through Medicaid.
Well, the obvious question is, Miss Israel, have you spoken to
Yes.
our lawmakers?
Lawmakers, Lord have mercy.
Well, they're the ones that could change this, or have you spoken to the Division of Medicaid?
Yes. The Division of Medicaid has made it clear that they do not cover obesity counseling, directed me to talk to the health plans. The health plans do not cover obesity counseling. The health plans have some superficial approach towards patients, whether they're pregnant or not, who they consider may be at high risk. They may get a phone call from a nurse.
Okay, so as you well know, Medicaid is a shared cost program between the federal government and the state. And so and the federal government picks up the majority. In fact, it has to pick up by law, by federal law, at least 50%. Mississippi has the highest federal match because we're the poorest state. It's based on per capita income. So I wonder if the reason Medicaid opposes your idea is because...
I'm not saying it opposes my idea.
Well, okay, well, they haven't adopted it yet.
Maybe
though, right?
Because we don't have the right people thinking and making policies.
Hold on a second. Let me ask this question. And I haven't researched it, and I'm not sure you have, but obviously you know quite a bit about this issue of obesity. Is it because the federal government in its reimbursement for Medicaid services won't pay for obesity counseling?
I don't know.
Okay.
I don't know.
Okay.
I've tried. I'm trying to get an audience with the chairman of Medicaid in the House to have this discussion.
The U.S. House? Or
the House here, State House here.
Okay.
Yeah. And I've made several phone calls to do that. I haven't had the opportunity to meet with him yet to talk about this.
Okay.
But I have talked to state lawmakers. Since I've been in graduate school, I've been talking about prevention and the need for supporting prevention. It's like I may as well be talking to that wall over there.
So again, I just wonder if it's not because the federal government.
Nobody has said that.
Well, that's I'm gonna see what I can find out because and I can also pretty confident that many of them are listening, both at the state and the federal level, and I think we need to get to the bottom of that because if it is a situation where the federal government will reimburse providers such as yourself for such services, and the state's part of it, which presently is 16% of costs. The federal government's picking up 84%, right, because there's a 6% addition from the COVID relief bills that passed in 2020. I just wonder if that's the reason, if that's the holdback, but we need to dig into that. It makes a lot more sense to me to spend money on preventative services because that saves us money down the road.
A lot of money.
I mean, that just stands to reason, pretty logical. And you're, honestly, Ms. Israel, your stance and your position that we need to introduce more personal responsibility, and if we're giving you something, we need something in return. I think most people are on board with that. I can't imagine why they're not. I think this is an issue where the reimbursement is a challenge, and we got to look into that. But I appreciate you coming on and explaining your position and what the root causes are here. I think most people out there listening would say, yeah, she's right. So let's see what we can do.
Okay.
Appreciate it.
Thank you.
Thank you for stepping
Enjoyed
aside.
it.